You have been told it is just snoring. Your partner nudges you. You roll over. And in the morning, nobody talks about it. Maybe there is a joke at breakfast. Maybe there is not. But here is what nobody at your last doctor's appointment said to you, and what I am going to say to you right now in the first 60 seconds of this video. Every single time you stop breathing in the night, and if you snore, you are stopping, sometimes 30, sometimes 60, sometimes over 100 times per hour. Your brain is being deprived of oxygen. Not enough to kill you in the moment, just enough to damage you slowly. And the organ that takes the damage first, before your heart, before your blood pressure, before anything else shows up on a standard lab panel, is the one you rely on most. Your memory, your ability to think, your ability to find the word that was just there a second ago and is now completely gone. I have been practicing medicine for 15 years. My name is Dr. David Miller, and I built this channel because there is a gap between what the research says and what patients actually hear in a clinic. That gap cost people years of cognitive function they did not have to lose. Subscribe to Dr. Miller right now and hit the like button. It takes 4 seconds. We are building a channel on one principle. You deserve to understand your own body completely, not just receive a prescription and a follow-up appointment in 6 months. Let me tell you about a patient I will call Robert. He was 67 years old, retired engineer, precise man, someone who had spent his career solving problems systematically. He came to see me because his wife had insisted. She had noticed things he had not. He was repeating stories. He was losing track of conversations mid-sentence. He had put his car keys in the refrigerator twice in 3 months and laughed both times. But the second time the laugh had not quite reached his eyes. He told me he felt fine. 7 hours every night, he said. He felt tired in the mornings, but assumed that was simply what 67 felt like. I asked him one question that changed the entire direction of the appointment. I asked him whether anyone had ever told him he snored. He looked slightly embarrassed. His wife, sitting beside him, did not look embarrassed at all. She said he had been snoring for at least 15 years. She said there were nights she could hear him from the hallway with the door closed. She said there were moments, 2 or 3 times a night, where the snoring stopped entirely for what felt like a terrifyingly long time. And then he would gasp and shift, and it would begin again. Robert had no memory of any of this. As far as he knew, he slept perfectly. That is the nature of the condition. It happens to you while you are unconscious, and it leaves no trace you can feel in the moment. The trace it leaves is in your brain, accumulated over years, and it shows up as exactly what Robert's wife had been watching happen to her husband slowly, steadily, and entirely preventably. What I want to do in this video is explain to you precisely what is happening inside the brain of someone who snores and stops breathing during sleep, not in vague terms, in the specific biological language of what is actually being destroyed and why. And then I want to give you a clear protocol, because understanding the mechanism without knowing what to do about it is just anxiety with extra steps. Here is the anatomy of what happens. When you fall asleep, the muscles throughout your body relax, including the muscles of your throat and airway. In a person with a normally sized airway and good muscle tone, this relaxation is partial. The airway stays open. Air moves in and out quietly. But in a significant portion of adults, particularly after the age of 50, and particularly in people who carry any extra weight in the neck and jaw region, the relaxation goes further. The soft tissue at the back of the throat, the tongue, the soft palate, the uvula, these structures partially collapse inward. The airway narrows. Air is forced through a smaller opening and the tissue vibrates. That vibration is the sound you hear from the hallway. That sound is not harmless noise. It is the audible signal of a structurally compromised airway. Now when that airway narrows further and closes completely, something critical happens. Airflow stops. Oxygen stops entering the blood. The level of oxygen in your bloodstream begins to fall. Your brain, which is monitoring oxygen levels continuously even during sleep, detects the drop. It sends an emergency signal. The signal partially rouses you, just enough to tighten the airway muscles and reopen the passage. You gasp, you shift, you snort, and you fall back to sleep within seconds, with no conscious awareness that any of this occurred. This cycle is called an apnea event, and in people with moderate to severe obstructive sleep apnea, it happens dozens or hundreds of times per night. Robert's sleep study showed 34 apnea events per hour. That means every 90 seconds on average, his breathing stopped and his oxygen dropped. Every 90 seconds, for 7 hours, his brain was being deprived of the oxygen it needed to complete its work. And this had been happening, by his wife's account, for 15 years. Subscribe to Dr. Miller and hit like if you are watching this and recognizing something you have been putting off thinking about. This channel exists because the conversation I am having with you right now does not happen in a standard clinic visit. Hit subscribe. It costs you nothing, and it means the next person who needs this information can find it. Now I want to explain the specific mechanism by which disrupted breathing during sleep destroys memory. Because this is where the research of the last 15 years has converged on something genuinely important, and almost none of it has reached the general public. During the deepest phases of sleep, the phases called slow-wave sleep and REM sleep, the brain does something it cannot do while you are awake. It cleans itself. There is a network of microscopic channels throughout the brain tissue, running alongside blood vessels, called the glymphatic system. During deep sleep, the cells of the brain actually shrink slightly, about 60% of their waking volume, and this shrinkage opens these channels. Cerebrospinal fluid, the clear fluid that surrounds and cushions the brain, is pumped through these channels under pressure. It flows through the tissue, collecting the metabolic waste products that have accumulated during the day's brain activity, and carries them out to be cleared from the body. This is a physical cleaning process documented in peer-reviewed research. Among the waste products cleared is amyloid beta, the same protein that forms the plaques found in Alzheimer's brains. In a healthy person with healthy sleep, it is cleared nightly before it can accumulate. In a person whose sleep is fragmented by repeated apnea events, the brain never reaches the sustained deep sleep required for full glymphatic activity. Night after night, year after year, amyloid beta accumulates faster than it is removed. Robert had been accumulating this protein for 15 years. His neurologist had noted no significant findings on cognitive screening 2 years earlier. What that neurologist had not measured was what was building silently in his white matter every night. Standard cognitive screening tests detect deficits that have already become significant. They are not designed to detect the years of accumulation that precede those deficits. By the time a screening test catches the problem, you have already spent years losing ground you did not have to lose. Beyond the glymphatic mechanism, apnea damages the brain through a second pathway operating in real time with every oxygen drop. When blood oxygen falls during an apnea event, brain tissue becomes hypoxic, oxygen-starved. Neurons are running on less fuel than they need. The brain releases inflammatory compounds as an emergency response. But when this emergency response is triggered dozens of times per night over years, the chronic inflammation it generates degrades the walls of the small blood vessels supplying the brain's deepest structures. The regions most vulnerable to this vascular damage are, again, the white matter and the hippocampus, the same structures essential for memory formation, word retrieval, and processing speed. Robert's MRI showed white matter signal abnormalities in the deep structures of both hemispheres. His neurologist had described them as age-appropriate changes. That phrase is one of the most dangerous in clinical language because it implies inevitability where there is actually causation. Those changes were not caused by age. They were caused by 15 years of oxygen deprivation and vascular inflammation. Age was not the driver. Untreated apnea was the driver. And that distinction matters enormously, because one of those things cannot be changed and the other absolutely can. Now consider what these oxygen numbers actually mean. A healthy person's blood oxygen saturation while awake is between 95 and 100%. During a severe apnea event, that saturation can drop to 70% or below. A saturation of 70% in a conscious hospital patient triggers an immediate emergency response. It is the level at which brain tissue begins to sustain direct damage. Robert was hitting saturations in the low 80s regularly, predictably, every single night. The third mechanism I want to explain operates through a hormone, and this is the one that connects sleep apnea most directly to the accelerated memory loss that Robert's wife had been observing. The hormone is called cortisol. Cortisol is the body's primary stress hormone. In the short term, it is essential. It sharpens attention, mobilizes energy, prepares the body for action. But each apnea event, each moment of oxygen deprivation and partial arousal, triggers a cortisol spike. The brain detects a threat. It releases cortisol to respond. In a person with 34 apnea events per hour, that is 34 cortisol spikes per hour across 7 hours of sleep. The total cortisol load accumulated during a single night is enormous, and the structure most vulnerable to sustained cortisol elevation is the hippocampus. The hippocampus is densely packed with cortisol receptors. Short-term cortisol sharpens the hippocampus. Chronic, sustained, repeated cortisol exposure degrades it. The tissue thins. The volume decreases. This is measurable on imaging, and it manifests functionally as exactly what Robert was experiencing. Names that won't come, stories told twice, thoughts that evaporate before they finish forming. This is not an abstract risk. A significant body of published research now links untreated obstructive sleep apnea to accelerated hippocampal atrophy, which simply means shrinkage of the hippocampus, at rates measurably faster than in people without the condition. The research also shows that treatment of the apnea slows or halts this atrophy. The brain does not have to keep losing ground, but it requires intervention. And the window in which that intervention produces the most significant benefit is before the damage becomes irreversible, which is exactly why I am telling you this now, before your next routine appointment where the subject may not come up at all. Let me now give you the practical information. Because the point of understanding the mechanism is not to frighten you, it is to give you a clear direction. The first thing I want you to do is take stock of the signs because snoring is not the only indicator. The classic pattern is this. You sleep for what seems like an adequate number of hours and you wake up tired. Not slightly tired, consistently, reliably unrefreshed, as though the sleep did not count. A heaviness in the first 2 hours of the morning that coffee only partially addresses. A mild headache on waking that clears within an hour. Brain fog through the day. A slowness in processing that is different from simple tiredness. And in the evening, falling asleep almost involuntarily if you sit still in a warm room. If 3 or more of those describe you, the next step is straightforward. You need a sleep study. A formal polysomnography, either in a sleep clinic or with a validated home testing device, which measures your oxygen saturation, your breathing pattern, your heart rate, and your sleep architecture across the night. This is not an optional investigation for people with the symptom pattern I have described. It is the essential diagnostic step. Everything else, every supplement, every breathing exercise, every dietary change will work around the margins if the central problem, repeated airway obstruction and oxygen deprivation throughout the night, is not directly addressed. Subscribe to Dr. Miller and hit the like button. If you have a family member or a friend who is always tired, always a little foggy, always snoring, and always being told it is nothing to worry about, share this video with them. The information in this video is not complex or experimental. It is established science that is simply not making it from the research literature into the rooms where people need to hear it. Every share puts it in front of someone who may genuinely need it. The most effective treatment for obstructive sleep apnea is continuous positive airway pressure therapy, a machine that delivers a continuous gentle stream of pressurized air through a mask worn during sleep, maintaining the airway in an open position throughout the night and preventing the collapse that causes both the snoring and the oxygen drops. I know this is not what anyone wants to hear. A mask, a machine, every night. What I will tell you is this. The cognitive research on CPAP and brain function is among the most consistent findings in sleep medicine. Studies show measurable improvements in memory, attention, and processing speed within weeks to months of starting regular use. Not because the therapy is magical, because the brain, finally receiving uninterrupted oxygen and completing its deep sleep architecture and glymphatic cleaning cycle, recovers function that was suppressed, not destroyed. The tissue was there. The capacity was there. It was simply not being allowed to operate. For people who cannot tolerate CPAP, alternatives exist. Mandibular advancement devices hold the lower jaw slightly forward during sleep, changing the airway geometry and reducing collapse. clinically meaningful for mild to moderate cases and better tolerated by many patients. Positional therapy uses modified sleep positions to prevent back sleeping in people with position-dependent apnea. Surgical options exist for specific anatomical contributors, and hypoglossal nerve stimulation, an implanted device that prevents the tongue from falling back during sleep, has shown strong results in patients who cannot tolerate CPAP. The treatment landscape is broader than it was a decade ago, but none of it can be matched to your situation without a sleep study first. Now, while you are arranging that evaluation, there are things you can do immediately that will reduce the severity of apnea and improve sleep quality, even if they do not eliminate the underlying problem. Position matters. The single most impactful behavioral change for positional apnea is sleeping on your side rather than your back. When you lie on your back, gravity pulls the tongue and soft palate directly backward toward the airway. On your side, this does not happen. The anatomical geometry is fundamentally different. In people with mild to moderate apnea, a consistent side sleeping position can reduce apnea events by 30 to 50%. The difficulty is maintaining it throughout the night. One approach that has clinical evidence behind it is sewing a tennis ball into the back of a sleep shirt, a low-technology solution that works by making the supine position uncomfortable enough that you shift without fully waking. It is not elegant. It is effective in the right population. Alcohol in the evening is one of the most significant and consistently underappreciated contributors to apnea severity. It relaxes the pharyngeal muscles that hold the airway open more completely than any other commonly consumed substance. A person who has 2 glasses of wine with dinner may have an apnea index 2 to 3 times worse that night than on nights they abstain. I have had patients whose results shifted from severe to moderate based on eliminating evening alcohol alone. It was not the only problem, but it was a significant contributor that was immediately removable. Weight in the neck region is a structural contributor to airway narrowing during sleep. Modest reductions in neck circumference have been associated with meaningful reductions in apnea severity. Losing weight does not cure apnea in most people, and severe cases require direct treatment regardless. But it is a real and modifiable factor that works alongside the primary treatment, not instead of it. Here is your clear summary. Snoring is not harmless noise. It is the audible signal of a compromised airway. When that airway closes, breathing stops, oxygen drops, the brain sends an emergency signal that partially wakes you, and the cycle repeats. Over years, 3 things accumulate. The glymphatic cleaning system cannot complete its work because deep sleep is fragmented. Repeated oxygen drops generate chronic vascular inflammation that damages the small vessels feeding the hippocampus and white matter. And each apnea event's cortisol spike chronically stresses the hippocampus, accelerating the volume loss that shows up as memory decline. These are documented biological mechanisms with a direct connection from snoring to cognitive function, and all of them are addressable. Starting tonight, take honest stock of your sleep quality. Do you wake refreshed? Do you feel brain fog consistently through the day? Has anyone told you that you snore, stop breathing, or gasp during sleep? If the answer to any of those is yes, arrange a sleep study. In the meantime, sleep on your side, eliminate alcohol in the 3 hours before bed, and if you are carrying weight in the neck and jaw region, begin addressing it through consistent dietary changes. These are not cures. They are immediate risk reduction steps while you pursue the diagnostic pathway that can get you to the right treatment. How old are you? Write it in the comments right now. I want to see the age distribution of the people watching this channel because it directly determines what I cover next. If the majority of you are in your 60s, I want to go deeper on the relationship between sleep apnea and cardiovascular risk because the heart and brain share this exposure and the implications for both are significant. If many of you are in your 70s, I want to address what the evidence actually shows about cognitive recovery after treatment begins at that stage because it is more encouraging than most people expect. Robert came back to see me 7 months after his diagnosis. He had been using CPAP consistently for 5 of those months. His wife had come with him again. She told me, before he had a chance to say anything, that he had not repeated a story in 3 months, that he had started finishing his sentences again, that the man she had watched slowly becoming less present over the previous 2 years was coming back. Robert told me that the change had been gradual enough that he had not fully noticed it happening, and that was the part that unsettled him most. That he had been losing ground so slowly that it had felt like nothing. The way the tide goes out. You don't see it moving, but eventually you look up and the water is a long way from where it was. Your brain is not failing because of your age. In the majority of cases, it is failing because of what is happening to it while you sleep. That is a distinction that contains an enormous amount of hope, because what is happening while you sleep can be measured, diagnosed, and treated. The ground you have lost does not have to keep going. I'm Dr. David Miller, and I have spent 15 years watching the gap between what the research shows and what patients actually hear cost people cognitive function they did not have to lose. Subscribe to Dr. Miller. Hit the like button. Share this with anyone in your life who snores and has been told it is nothing to worry about. The healthcare system will manage your symptoms when they become severe enough to appear on a screening test. This channel exists so that you do not have to wait until that point. Subscribe if that difference matters to you. This content is educational in nature and does not constitute personalized medical advice. If you are experiencing symptoms of sleep apnea or cognitive decline, please speak with your physician about appropriate evaluation. The mechanisms and interventions discussed here should be explored in partnership with a qualified healthcare provider who knows your individual medical history.